Good morning, everybody. So last clinic of the year, and we're excited. It feels like winter. The winter starts today, and the weather is in keeping with that. We hope you all have a very Merry Christmas and Happy Holiday season. And we are really, we put together some data about echo this year and compared it to our echo data for 2016. And we're going to disseminate that to everybody. But the major bit of information is that our echo participation was up about 60 or 70% year over year. So really a dramatic increase. Now, we're doing some things differently. We have some new clinics. We phased out some older clinics, but overall our echo participation rates have really increased. So we're thrilled with that and can't wait to see how 2018 works out. We have somebody new who's just joined us, new or back home in Nevada. Danny, you want to introduce yourself?
Sure. Hello, good morning, everyone. My name is Danny Villalobos, born and raised here at local rural Nevada, and went to UNR for undergraduate and went to University of Utah for PA school and just returned in August and back in Nevada and rural Nevada. So glad to be home and take care of our people.
So welcome. We're delighted to have you.
Thank you.
We hope that echo really provides, it turns out to be a great adjunct in your practice, and that hopefully you'll have time during your busy workday to participate in not only this clinic but others that you feel can add value.
Yeah, I'm excited. I've heard a lot of good about you. So.
Well, terrific.
Yeah.
So we had no cases submitted. One of the things we're hoping for in 2018 is that our online case submission forms will finally see the light of day. We know we're close, but we ain't there yet. But hopefully that's going to be ready for launch sometime in the first quarter of 2018. I think that will make case submission simpler and more efficient and less of a burden, and hopefully increase the number of submitted cases, because that's how we make for the best discussion. You don't want to just listen to us blabbing at you. But we're willing to do it. The thread is we will keep blabbing at you unless you give us something else to talk about. So anybody, without having submitted a case, have anything that they're struggling with or have questions about in the endocrine and diabetes realm? If not, think about it, and maybe a spark will ignite as you get tired of hearing me blab at you. Anyway, we will, I'm not going to talk for that long, but if you have a case, we'll be happy to address it before we close out for the day and for the year. What I wanted to talk about this morning is medication-induced hypoglycemia. Health Insight, our quality improvement organization, had asked me to do a webinar for them on this topic, which I did a few weeks back. And Health Insight, as you know, covers several states: Nevada, Utah, New Mexico, and Oregon. And it's an interesting organization because they really do have their finger on the pulse of what the federal government is interested in terms of healthcare indicators. So when they wanted a discussion on hypoglycemia, it was a tip-off that at the highest levels of government at CMS, there's concern about hypoglycemia and its impact not only on patients but on costs of healthcare. So I had done that webinar for them, and I said, this would be worth discussing in ECHO as well. And I streamlined the talk a little bit, but I thought it was worth going through. So do I have control here? Yeah. Okay. Okay. Can everybody see the slides? Okay. Good. So this is a thing, hypoglycemia that occurs in our patients is not a benign event. It can be benign, right? So we have patients commonly who have mild adrenergic symptoms of hypoglycemia. They get a little sweaty, they get a little anxious, maybe they have palpitations, and it's that adrenergic warning system that provokes a response, generally eating. But patients become somewhat accustomed to hypoglycemia, and those adrenergic warning signs tend to dissipate over time. So that patients begin to tolerate lower and lower blood sugars the more frequently they're hypoglycemic. And what happens then is that they don't become aware of their hypoglycemia developing, and they develop neuroglycopenic symptoms. Neuroglycopenic symptoms, confusion, lethargy, and the like, seizures, etc. And I think about those events as being similar to being hit over the head. And each time you get hit over the head, there are consequences. The recovery may seem to be 100% complete, but those events tend to be additive over time. And each one of those brain insults takes a toll. And over the course of time, lasting cognitive impairment can occur. So it's like getting hit over the head with a soccer ball or with a 2x4. It's not a benign event. And when patients report it, we need to really think about the scenarios in which it's occurring. And when they don't report it, we really need to probe a little bit. We need to really be thinking about whether our patients are experiencing hypoglycemia. And one of the other consequences of hypoglycemia is that it triggers a set of responses which are counterproductive, right? Low blood sugars beget high blood sugars. And then that cycle of hypoglycemia followed by hyperglycemia creates all sorts of struggles for us in terms of how we modify patients' therapies. And obviously, some of the drugs we use are much more problematic than others. So we'll talk more about that. So this is not just a local phenomenon. This, as I was preparing this talk, Endocrine news came in my mailbox. And so this was a November 7, 2017 issue. And you can see this is dealing with hypoglycemia in elderly patients. And obviously something of great concern nationwide. This also showed up in an email at the time I was preparing this talk. And this talks about an FDA effort to develop continuing education programs for providers to reduce hypoglycemic events. So this is on the radar at the highest levels of government and of our professional societies. And it is one of the Healthy People 2020 goals to reduce insulin-induced hypoglycemia. So I bring this to you all because I think it is something that we need to focus on. And the reason that we're in this pickle is really what I want to talk about. But just to let you know, so we have almost 10% of the population has diabetes, and almost all of those have type 2 diabetes. This is a big disease. It's a big problem in our patients and in our practices. It causes death. It's the 7th leading cause of death and results in 14 million emergency department visits annually. And there are only 4,800 endocrinologists in the United States. So we ain't solving this problem. I'm happy to talk about it, but you all have to fix it, all right? Because I can't see 6,000 patients. So this is an all hands on deck issue, I think, and I think shining some light on it is really important. So if we just look at ED visits for adverse drug events, they're pretty common. 4 visits per 1,000 persons are for adverse drug events. 27%, a quarter of those result in hospital admissions. 35% of those visits occurred in seniors, so those over the age of 65. And of the medicines responsible for these events, 5 of the top 15 are diabetes-related medicines. Insulin, far and away the leading culprit, not surprising. Metformin is on the list, I think because of the frequency with which it's prescribed and prescribed in combination. We all know that patients on metformin alone don't get hypoglycemic unless something else happens. But metformin, we know, will not cause hypoglycemia when used by itself. But in combination, it becomes a culprit, right? So we have patients on insulin and metformin, we have patients on sulfonylureas and metformin. And of these sulfonylureas listed, it's the long-acting sulfonylureas, glyburide, glimepiride, that are the prime problems. And if we look at the Beers criteria, I don't know if everyone is familiar with Beers criteria, but Beers, it's a system of evaluating drug risk in the elderly. And on the list of medicines to never use are long-acting sulfonylureas and insulin, short-acting insulin by sliding scale. But not on the list is insulin in general. And not on the list are the other big culprits for adverse drug events, which are anticoagulants and opioids, right? Not terribly surprising. Why? Because you need to use these drugs, right? We can't make a blanket statement that these drugs ought not to be used in seniors because we have to use them, but we need to be smart about them. But there are certain drugs in this group that we probably should just take out of our armamentarium. Glyburide, glimepiride, and I will just make a sidebar here that glipizide extended release is a drug that makes no sense to me, and I hope to you as well, right? The value of glipizide is that it's a short-acting drug, right? If we now make it a long-acting drug, then I'm not sure what we've accomplished except supporting our pharmaceutical colleagues. So short-acting glipizide, a drug that can be used but cautiously because we all know it'll cause hypoglycemia. So how did we get here? And I always like to talk a little bit about history because I think history kind of sets us up for the problems that we face in all different scenarios. So when I was a fellow, so back in 1980, I read an article in Diabetes Care. You know, Diabetes Care is our primary clinical diabetes journal, publication of the ADA. And the first volume of Diabetes Care was published in 1978. So 2 long papers by a fellow named Jean Perrart, who is a Belgian family doctor, who reported his personal observations of 4,400 patients who he had been treating over many years. And what he did in that paper was really kind of miraculous in a sense. He evaluated and estimated the degree of glycemic control in his patients and correlated that with development of microvascular complications, retinopathy, neuropathy, nephropathy. So he had 4,400 patients that he evaluated over the course of up to 30 years. And based on his clinical judgment, had graded their degree of control and correlated that with outcomes. So not, you know, this was no double-blind controlled study. However, this was a very big clinical experience. And what he demonstrated in his practice was that diabetes control mattered in terms of development of microvascular complications. Now, we all take that as an article of faith, but in 1980, this was not an article of faith. There were 2 camps in the diabetes world who would kill each other if they were in a room together, because one group said diabetes control does not matter, that microvascular complications are a totally independent event from blood sugar control. And the other group believed that blood sugar control mattered. Perart's paper was the first paper that had any real traction in terms of shifting the argument towards improved glycemic control to prevent complications. So it was a really, it was a milestone. And it's funny that, you know, the way we look at the literature these days is so hard-nosed and hard-edged, right? If it's not a perfectly done study, we ignore it. But this was a single doctor seeing several thousand patients and changing the world. Pretty amazing. So remember, in 1980, we were not doing fingerstick blood glucose monitoring. We didn't have hemoglobin A1C. Once those became available, we were able to actually inflict on patients strenuous efforts to control their blood sugars, because we finally knew what their blood sugars were, right? Back in 1980, we would have patients come to clinic with a 24-hour urine glucose. That was how we assessed their control. And of course, patients knew they were coming. You know, they could control for a day or two before clinic and come in with a 24-hour urine with no glucose. So we had no good tool until we developed fingerstick glucose monitoring, A1C measurements, early 80s. And of course, our new delivery systems give us means of prescribing insulin that are much more convenient to patients, and I believe genuinely improve compliance, and I think to some degree also improve the ability to control blood sugars better. And we've got a million new medicines, right? We're not going to talk about them today. We all know there are a million drugs, 72 different classes of medicine. And we also know that where there are new drugs, there's lots of money, and there's heavy pharmaceutical company engagement and pressure to prescribe in different ways. And it's the pharmaceutical industry that, to a great degree, has pushed tighter and tighter glycemic targets. So how did we get here? Well, following Perart's paper, there were two landmark studies, and I don't think this will come as news, but the first was probably the most important, which was the Diabetes Control and Complications Trial, right? A study of thousands of patients with type 1 diabetes that did two things. First of all, proved you could control these patients to low levels of hemoglobin A1C, and secondly, demonstrated that there was correlation with glycemic control and microvascular complications. And the second was the United Kingdom prospective diabetes study, which looked at thousands of patients with type 2 diabetes and looked at multiple parameters. There were about 25 papers that came from this study looking at all aspects of diabetes control, hypertension control, and risks of complications, both microvascular and macrovascular. An enormously important study that appeared around in the early 2000s. So this was the header for the DCCT study. As you can see, it was released September 30th, 1993. Truly a landmark study, and really changed the world for us in one fell swoop. So this was what they were able to do in the DCCT, right? So the top bar on the left is conventional control. So conventional control then meant NPH and regular insulin, basically. Human, but still NPH and regular. And you can see that mean A1Cs were about 9 with fairly broad ranges. The bottom bar on that side was intensive control. So those were patients on multiple daily injections or on insulin pumps. And the investigators were able to force A1Cs down to 7.2% on average, which was a remarkable thing. To the right, you can see what the future looked like. So this, again, the EDIC study, we ought to talk about it some other time. It's a fascinating study, but that was the follow-on to the DCCT. And EDIC looked at what happens once you took the reins off of patients in the tight control group, but also demonstrated the changes over time. So when EDIC started, our conventional therapy was better, and patients then in both the conventional and the intensive care, in the intensive group, achieved A1Cs that were kind of halfway between intensive and conventional in the DCCT. And they were able to maintain that level of control, A1Cs have been in the 8 range, over many years, and reported on those studies, the most important one of which was the legacy effect. And that was the demonstration that even after relaxing intensive control, the patients in the intensive group still had lower risks of microvascular disease. But that's a topic for another time. So this was the UK PDS study. So this one appeared in 2002. And as I said, this was a series of many, many papers looking at all sorts of diabetes outcomes, and just fascinating reading. Most of them were published in the BMJ, British Medical Journal. So DCCT proved that microvascular complications correlated with A1C in type 1, and the UK PDS similar findings in type 2. And the question became, well, how low is low enough, right? Is 8 good? Is 7 good? Is 5 the goal? You know, those were unanswered questions at that time. So this is a modification of the DCCT outcomes. And as you can see, microvascular complications rise as we move to the right. Can I do this? Oh, okay. So over here, microvascular complication rates high, whether it's retinopathy, nephropathy, neuropathy. But as we push towards the left, those risks go down. And at our American Diabetes Association goal of 7, there's really no difference in risk amongst all of those groups. And you can say that the difference between 6 and 7, marginal, right? So it looks like pushing A1Cs down is a pure win. But this is the other end of that spectrum, okay? Because this line running towards the left is risk of severe hypoglycemia, okay? And as we hit our ADA goal, oh, that's cool, of an A1C of about 7, you can see that we are looking at about 70 severe hypoglycemic episodes per 100 patient years, right? So this is an issue. And for a long time, we kind of trivialized it, would you say? I mean, we kind of didn't really worry much about it because our mandate was to force down A1Cs. And we got pretty good at that. But I think now we're smarter. We also have better treatment algorithms. But we need to factor in this countervailing event. So this is a kind of a complicated slide, but I want to just look at this panel here, okay? And what this looks at is risk of hypoglycemia in patients with comorbidities, all right? So, and these are patients with type 2. And as their complexity increases from low to high complexity with intensive therapy, you can see that risk of hypoglycemia goes up dramatically, all right? So the more comorbidities the patient has, the greater the risk of intensive treatment. And look at the difference between high complexity with standard treatment and high complexity with intensive treatment. So you know your patients best, all right? And what I'm saying is that we need to, you know, this is an era of personalized medicine, and part of personalized medicine, it's not just genomics, right? This is actually evaluating our patients based on our assessment of their abilities to comply with the regimen, the complexities of their regimen, and to think about them in a more holistic way. Now, maybe someday artificial intelligence will do this for us. But right now, we have to use our own artificial intelligence, which means we have to make it up. And by making it up, I mean, we have to just really spend that time and think about the hazards of the treatment. We think about hazards all the time, right? We put a patient on an antihypertensive. We want to know, do they have orthostatic symptoms? Are they bottoming out from time to time? We need to be thinking about their hypoglycemia risk. So this interesting slide shows what has happened to hospitalizations in relation to diabetes over time. So the bar, this bar, is hyperglycemia related hospital admissions. And as you can see, we've done pretty darn well in the, in the 15 years or so, and actually since the UK PDS primarily, that we've done great at not letting hyperglycemia cause hospital admissions. Now, part of it is changes in practice, right? Patients show up in the ER now with a blood sugar of 300. In the 90s, we might admit them to the hospital, right? We clearly don't do that anymore. So there's some cultural change here too. But I think it's also because we are lowering ambient blood sugars over time. But the risks of hospitalization for hypoglycemia have persisted and now far outnumber our hyperglycemia admissions. Now, what about intensive therapy and dying? Well, dying is bad. Dying is also an outcome that is pretty easy to measure, right? It's a binary thing. You're either dead or you're not dead. And I'm always a little facetious, but this study, so this was the Accord study. This was a very, very important study looking at intensive therapy in patients with type 2 diabetes who were at high risk for cardiovascular events. All right, so these were patients who either had heart disease or had very high risk profiles for heart disease. And what was demonstrated in this study, and the study was actually terminated early because intensive therapy had worse outcomes, okay? Not in terms of cardiovascular events. So didn't reduce it, so there was improvement, small improvement in heart attack and stroke. But outcomes in terms of death actually were higher. So all-cause mortality was higher in the intensive therapy group. And the study was stopped at 3.5 years because those outcomes were felt to be substantial and real. So this was a fabulous demonstration in 2008 of the global risk posed by intensive therapy. So this was kind of an unintended and surprise outcome, right? We're looking to prevent heart attack, stroke, and cardiovascular death. And what we're finding is all-cause mortality is actually increased. So this is really not anything that we could easily blow up. And these are hazard ratios. Basically, in the panel on the right, we can see that standard therapy was better in almost every outcome. Now, standard therapy was A1Cs in the 8 to 9 range, I think. Okay, so not horrible. These were not A1Cs of 13, but they were not 6.5 and 7, which they were in the intensive group. So I'm throwing this up not to really talk about treatment algorithms, because we'll talk about that at another time, just to demonstrate the extreme variability of treatment regimens that can be prescribed, but also focusing on advancement of therapy. And again, I want to just throw a little bit of caution in here. We want to treat to target, absolutely. But we also want to ensure that before we advance therapy, patients are really complying with the regimens that we're laying out, and before we advance, that we haven't caused a new problem in the interim. So this was an interesting paper that was published just this year, and this was a pharmacy utilization review. And what was demonstrated here, I think, is so important, because what they looked at was advancement from metformin to a second agent. What they demonstrated was that patients were moving on to a second agent before metformin had either been given an adequate trial, either adequate in dosage or in duration, but there was also demonstration that patients were not taking the drug as prescribed. So remember, metformin is our golden drug, right? It's a miracle drug, right? 1995 was a banner year when metformin became available in this country. But we've got to use it properly. And we've talked about this before, but properly means proper dosing, which means, full dosage. Remember what we're managing. Remember what our goal with therapy is. It is not glycemic control, but reduction in insulin resistance. And we can't measure that well. So we want to make sure that patients who are going to take metformin are on their best tolerated dose, ideally 1,000 BID if they can get away with it. But before we add a second drug, you want to be sure that metformin has been optimized, right? Is the patient truly taking it? Are they having diarrhea and not taking it? Or are they having diarrhea and still taking it, and maybe they shouldn't be? But before you advance, just try to ensure that you've optimized use of metformin. All right, slide that's going to be difficult to read, but it's in there just because it's a reminder of the reasons that people end up hypoglycemia. And some of the terms are cute. Meal-related misadventure, right? Patients not timing their meals properly, missing meals, etc. An unrestrained 19-year-old female hits a tree and a brick wall. Blood sugar was 24, right? Or a 75-year-old man who had a syncopal episode with a blood sugar in 20s because he missed lunch, right? These are the things that happen. And when we use long-duration sulfonylureas or long-acting insulins, the risk of a meal-related misadventure increases, right? Unintentionally took the wrong insulin product. I think it's a little bit better now, but it was fairly common for patients to take short-acting insulin at bedtime instead of long-acting insulin. It was a little easier when we used cloudy and clear insulins. It was easier to differentiate the two. Now at least our pens are color-coded and I think easier to keep track of, but taking the wrong insulin product clearly happens. The older we get, the more often it happens. Missed dosing, or didn't remember if they took the dose, took a second dose, an additional dose. And pump-related misadventures are interesting because that number is quite small. And I frankly think that pump misadventures are something that we worry about, but I think we deal with not all that frequently. I think it's a combination of orals and insulin in older people where the real risk lies. So in seniors, prevalence of diabetes might be 25%. And these are complex patients with comorbidities on 1 million drugs. If you're like me, taking 2 drugs is complex. And since I'm over 65, I can tell you it has gotten worse in the past 2 weeks. Do I have cognitive impairment? Well, you can answer that for yourself. But polypharmacy, and the older we get, the higher the risk of these events occurring. And the risk of hospital admission increases 5 times in this age group. Risk of dementia increases with recurrent episodes of hypoglycemia. Falls increase, and fall-related fractures increase. Cardiovascular events occur. Quality of life is diminished. Why? Because patients don't want to feel that way. And they become obsessive about their glycemic control, and it weighs on them continuously. It's a huge quality of life issue. And mortality has increased, as we demonstrated in the ACCORD study. So there are many, many reasons for us to think about this. So these are the 2017 ADA targets for A1C. So in non-pregnant adults, we're still pushing for tight control, right? A1C is under 7. But even in that age group, we need to be conscious of the patient's capabilities in terms of managing control. In selected patients, pregnant women, for example, A1Cs down to 6.5 are still a target. It doesn't mean it's a demand, but it is a target is just a target. It's something we aim for. It doesn't mean we hit it all the time. Patients who are on metformin alone, absolutely, go for an A1C of 6.2, right? If we're treating patients who have either prediabetes or mild type 2 diabetes and are on metformin alone, if that were me, I would say, yeah, let's have an A1C of 6. But patients with severe hypoglycemia or advanced complications, A1C targets of 8 or lower are much more reasonable, right? We need to back off to eliminate hypoglycemia. And the fact is that as we back off to eliminate hypoglycemia, we sometimes see improvement in A1C because we have much less roller coaster control. And remember that patients with complications, well, that horse is out of the barn already, right? Tight control does not improve microvascular disease and if we think of microvascular disease as an indicator of systemic vascular disease, perhaps makes things worse. And in seniors, relaxed targets to prevent symptomatic hypoglycemia because of the quality of life aspect, and also consider what the patient's life expectancy is, right? If we have patients who are older, who don't have complications, their likelihood of developing complications in their lifetime, which is all we care about, is not very high, right? And in that case, hypoglycemia is not worth the risk because there's no demonstrable gain from tight control there. We don't want them to be symptomatically hyperglycemic either, right? So if they're polyuric and having nocturia, not so great, because if they're waking up to pee and they trip and fall in the bathroom, that's an adverse effect as well. But we need to target glycemic control realistically in these patients. And I had a couple of slides talking about hospital admission or hospitalization as an opportunity for diabetes control, but maybe we won't get into that unless there's any particular interest in talking about that. Let me say a couple of words. So my couple of words are this. Every patient who's admitted to the hospital with diabetes ought to have at least a cursory assessment of their treatment regimen. And by that I mean that we ought to know when a patient is admitted what their glycemic control has been. So an A1C at admission makes great sense because we can then say, all right, well, this is a patient who's been under appropriate glycemic control. Their treatment regimen seems to make sense, and we can plan then on them leaving the hospital on the same therapy. But for patients who we discover to have poor glycemic control, well, maybe this is an opportunity to rethink their treatment regimen and set more reasonable targets for them following discharge. And since we have resources available in the hospital that are difficult to access on the outside, it's an opportunity to bring the diabetes team in to reimagine what the patient's treatment regimen might look like and provide for some sort of post-discharge follow-up. Because without follow-up, we're just, you're shooting in the dark. So hospitalization is a chance to take a step back and say, hey, this is working, this is not working. If it's not working, what's wrong with the regimen? What can I impact? And how do I then transition that patient from my hospital team to the ambulatory side and hopefully improve that patient's control going forward. So, in summary, hypoglycemia is now more common as a cause of hospitalization than hyperglycemia. Our A1C targets maybe were overly aggressive in many patients, not in all patients, but in many patients, and they were not patient-centered, all right? A1C targets need to be specific for each patient. And that's a discussion with the patient, you know. What are the patient's goals? What do you as the clinician think are reasonable goals? And where do you identify risks with therapy, knowing that we are the culprit in many cases in terms of pushing patients towards targets that may be unachievable. It's both patient and prescriber errors that lead to contribute to this. And it's like everything else, it's worse when you're old. So we need to be particularly careful, even to the extent of eliminating therapy or eliminating glucose testing, right? Because testing begets action, right? The more testing we have our seniors do, the more focused on their blood sugars they're going to be, the more concerned that they're going to be when they see numbers that set off an adrenergic response by themselves. And sometimes testing doesn't really add much to the patient's outcome. So we need to think about, you know, optimal use of glucose monitoring as well, perhaps also a topic for another talk. And I'll quit then and see if anybody has any issues. Is this something that you're thinking about in management of your patients? Is this something that you think is an area where improvement might occur? I think that it's a great topic for quality improvement initiatives in clinic. I'd love to know what people's experiences have been, or if they have questions about how to confront this with their patients.
Please use the microphone icon in the lower left corner of your screen to unmute yourself.
Anybody have a patient who was admitted in the past year with hypoglycemia? I had one patient, young fellow, who had a fatal motorcycle accident, was hypoglycemic, heartbreaking. It's a while back, but I've had probably more than my share of patients who have been hypoglycemic, you know, and I think that even if patients don't report it, when we look at their glucose logs, we just need to, you know, we focus on the highs. I think we need to focus on the lows.
And when you think about hypoglycemia, it's one of those things for my patients, I ask about it every visit.
Yep.
So you have the 55-year-old who got in his car to drive wherever he was going, didn't check his blood sugar, and ends up 30 miles out of the way in a ditch.
Yep. With
low blood sugar. The elderly patient that I had that got out of the bed to go to the bathroom fell and broke her hip, her shoulder, her arm, and seized.
Oh my God. So that was the
So that was it. So that's a long, prolonged hospital stay and a couple of surgeries.
Yeah.
So hypoglycemia is one of those things that really should be assessed for at every visit for any patient, certainly any patients on insulin therapy, regardless of age. Because the younger people, if you don't ask, they don't tell, but they have a lot of hypoglycemia, and certainly older patients. And to the point of testing, for my older patients, I will tell you, and this is my bias, they're over the age of 75, depending on their treatment. I'm not having them test 4 times a day
Mhm.
because they want to treat it. They've been taught over the years that you do not want high blood sugar. I have a 92-year-old who thinks that her A1C should be 6.5.
Mhm.
Retraining, no, it doesn't need to be 6.5. You're 92 years old. Your risk of complications is pretty low 5 years from now. So it's that kind of retraining them in regards to what their glycemic targets really should be.
Yeah.
And that takes a lot of time and work. But I don't have them test. You're 80 years old, you're testing once a day. And I usually have you test in the morning because I trust your blood sugar is going to be lower in the morning and you're not going to panic.
Okay, that's a good idea. Interesting.
It is a good point, though, to always ask about it because, even patients who have had diabetes for the last 30 years for type 1, that things change. And one gentleman who's had it, I think, for 25 years was out mowing the lawn and didn't have anything with him and had a hard time getting back into the house. So even reminding people to carry stuff with them, I think is important.
Absolutely.
So then they can, whether it's glucose tabs or fruit snacks or whatnot. Question.
Yeah. So, first, our next scheduled clinic is January the 4th, but I'm out that week, so I think we're gonna just have a somewhat prolonged holiday break, if that's okay. So we'll send out an announcement that we're gonna cancel clinic on the 4th, and we will regroup on the 18th. Veronica's gonna talk about basal bolus insulin therapy, and we'll launch into our 2018 curriculum. So, stay safe, have great holidays. Thanks for sharing with us. See you next year.